Well, hi, everybody. Welcome to the Critical Care course. I thought it would be appropriate to start out with figuring out exactly who critical care patients are. So you can see the slide deck here, and I'll let you read the objectives and such for yourself, look at some of the pretty pictures yourself. But let's get right into it and figure out who is it that requires ICU care. Well, trauma patients, people with cardiovascular disease, my personal favorite, surgical patients, patients in the medical world who have renal failure and respiratory disorders like pneumonia, ARDS, etc. GI disorders, GI bleeds and liver failure are very commonly seen in the intensive care unit. And then, of course, there are the very severe and life-threatening issues of shock that are seen routinely. And of course, there are many, many others. I did not include on here neurological problems. And of course, there are many of those. And people in my clinical group will see many of those this semester. We see different people working in ICUs, including many different therapists, respiratory therapists, physical therapists, occupational therapists, speech therapists, etc. But all the care in the intensive care unit is directed by physicians and oftentimes with the cooperation of nurse practitioners and physician assistants as well. One thing that we see in critical care, though, is that everybody has a voice in what happens. And in the best critical care units, that is true. So this is from a recent study that looked at what the characteristics of critically ill patients actually are. And you can see that they run the gamut from a variety of different organ systems involved, many different ages. The mean age, of course, being in the elderly, the young elderly are the represent the mean here. But older patients tend to be the ones who have more proclivity for intensive care just because of their disease burden. Intensive care units are very expensive. The average length of stay is 3.8 days. There are many different diagnoses, as we talked about, that are treated there. And many times this goes over 2 weeks. And at $2,000 a day or more just for the room, that gets expensive quickly. So a patient's experience in the intensive care unit is a function of many different things. But keep in mind that all of the things listed here and many others will have an impact on the patient's experience with their care. So the fact that people don't sleep well in the ICU is certainly paramount. There's sensory overload. There's lots of fear and anxiety about what's happening. And that's not just fear and anxiety on the patient's part, but also on the family members and friends and others. There is an instant loss of privacy, and patients do tend to be bothered by that if they're younger in particular. And none of these things are probably surprising to you. Patients who are asked later about their intensive care unit stay tend to remember the awful things and think about some of the things that we see patients going through, and hopefully we're dancing with them and trying to meet their needs and anticipate their needs first. Pain, thirst, anxiety, their thoughts of dread and impending death. Those things are often things that people notice. Loneliness is another one. Claire Fagan, who is the one of the former deans at the University of Pennsylvania and one of my heroes, her research actually in the 70s looked at children who were separated from their parents in the hospital. And as a result of her research, along with other things, but largely because of her research, we now don't separate families from their young children in the hospital. And believe it or not, up until the 1970s, that was really a common practice. And imagine the kids' loneliness that they were feeling, not to mention, obviously, the parents' feelings as well. And then lastly on this list here, lack of control. And you can imagine that's a big thing as well. So how can we manage some of these things? Well, by being good nurses, right? So being present, allowing patients to have control over the things that we can allow them to have control over. Some relaxation and breathing techniques can be useful. And some of the therapists in the hospital can be helpful as well. The music therapists at Hershey Medical Center, pet therapy can be another one. Therapeutic touch is on this list, but it has been universally, I'm trying to think of a nice way to say it, but it's bogus. And it has been proven actually by a 12-year-old in her science fair experiment that therapeutic touch is nonsense. So moving on. Remember that there are many different complications during an ICU stay, including some of the things that I am interested in studying, like catheter-associated UTI, that's CAUTI, CLABSI, which is central line-associated bloodstream infections, VAP, ventilator-acquired pneumonia, sepsis. These things are actually, the first three there are what we call nurse-sensitive outcomes. These are things that nurses have an impact on in the hospital, and in fact, we are judged based on the rates of CAUTI and CLABSI and falls and pressure ulcers and things like that. So don't think for a minute that nurses aren't important. They are critically important, and what we do and what we don't do can have a big impact on patients in their ICU stay, and whether they even need to go to the ICU. Remember that delirium and ICU psychosis are real things. We see them very, very frequently in the intensive care unit. And you think about it, there's no downtime. The place is always lit up. And even if it's not lit up, it's still loud. I mean, I walk onto the unit in the morning and I hear the nurses yelling from one end of the unit to the other. It's no wonder that patients are unable to sleep. Now, obviously, I get it. There's things that need to be done and whatnot, but it's just not a very friendly environment for patients to be in. Although, I will admit, obviously, nobody questions their need to be there, right? So other risk factors for delirium and ICU psychosis are elderly. And we saw the slide earlier that said that the average age in the intensive care unit now is 62. So keep in mind that when somebody is elderly, they may have some cognitive dysfunction to begin with, but when they're in their own surroundings, they're able to sort of keep it in check, right? They have constant reminders to reorient themselves. When we send them to the intensive care unit, they lose all that. They lose the references that they see around their house. They lose the people who they see or are accustomed to seeing, pets, etc. So elderly are certainly at high risk for delirium and psychosis. People who've been in a coma, people with pre-existing dementia, alcohol, people who have alcohol dependence, and many others. Remember that there are other things that worsen this too, things that we do to patients. Administration of opioids and benzos. Also, some of the cardiovascular drugs that we use for patients, and corticosteroids. Corticosteroids do have a tendency to make people psychotic, and I have stories about that from my own family. Not that I'm going to tell you that now, but, maybe on the unit if we're seeing patients together. There are assessment sheets that we use, and there are new ones coming out all the time. It's a big area of study, is to help figure out who these patients are, identify them early, and hopefully prevent patients from having these complications of hospitalization and ICU care. There are many interventions for delirious patients, and I caution you to think last about just drugging patients and giving them medicines that will snow them so that they are quiet for you the rest of the night. That's not the way that we should be dealing with this. There are other things that we can do, and we're going to talk about some of those things throughout this course. But remember that decreasing those stimuli, minimizing their knowledge that they're in the ICU and away from their usual surroundings, and maximizing things that that make them remember where they are. Family members, frequent visiting, I think, is usually helpful. Not always, of course, and that's up to you to decide. But remember that when we have patients in the ICU, it's more important that we treat the patient than when we treat the nurse, right? So I have worked with many nurses whose primary motivation is to get the family out of the room so that they can do what they need to do and that they're not inconvenienced. I would caution you to think first about the patient and what's best for the patient. And if that means waiving those silly visiting hours, then I think that's probably the best thing to do. We also need to remember that all the noise and carrying on in the ICU disrupts sleep, and if we can find a way to maximize patients' sleep, that is best done. There is such a thing as post-intensive care syndrome, and notice that the first two arrows here point to patient and family. So patient and family are both part of this process, and we have to make sure that we always are taking into account the family when we consider acute problems and their management. The family of the critically ill patient needs to be part of the patient's care. They need to hear what the updates are. They need to be present. They need to be involved. It always is concerning to me that I hear clinicians talk about how the family isn't involved and the family is never here and they don't know what's going on because they don't show an interest. And yet we close the doors and we don't let patients' families in. It drives me crazy. We need to make sure that we're partnering with the families to keep these patients on the road to recovery. There are tips for supporting family members listed here. Remember, involving them, listening to them, understanding what the unique issues are for this particular patient is really important to do. Have them write down questions for the ICU team if they need help doing so. I know my grandmother would have been willing to help them. She wrote down everything when my grandfather was in the hospital. I mean, everything. And she kept meticulous notes, and I'm sure it made the physicians crazy thinking that they were going to get sued. But she knew what was going on, and there was never a question. She wrote down everything, and I encourage patients and family members to do the same thing. Also, remember that you're not in this alone. You as the nurse have many other people and services that you can call on to help these patients and their families. Don't be afraid to get the chaplain services involved, particularly at Hershey. They're very good. If for no other reason, they are a dedicated person who can be with the patient while you have, or be with the family, while you attend to the patient in emergencies. So that can be very useful. Discharge planning starts on admission. I think that's an NCLEX thing. You might want to remember that. Discharge planning begins on admission, and we keep that in mind as we have patients in the ICU. Usually, patients come to us to the ICU from another floor in the hospital or directly from the emergency department. They're not usually admitted to the ICU directly from home, right? Rather, they come from a different unit. So we have to we have to remember that there's other data that needs to be taken into account than just what's been done in the ICU. We also have to know what else happened on the floor prior to them getting to us, or what is it that brought them to the hospital initially? Did they arrive by lifeline? A helicopter ride from 2 hours away is a very different scenario than somebody coming into the emergency department on their own because they, have an infected leg or whatever. So all of those things are important so that we can make the appropriate plans for discharge.